Hello and welcome to the Rural Health Ask, Advise, Refer to Quit, Don't Switch Brief Intervention Training. Today, during the Ask, Advise, Refer to Quit, Don't Switch training, we are going to review some important definitions, core beliefs about tobacco dependency treatment, rural populations, the brief intervention model, and break down key points. In addition, we will discuss how to conduct a follow-up visit, relapse prevention, and most importantly, we will work through a few sample case studies to practice Ask, Advise, Refer to Quit, Don't Switch. It is important that we are all on the same page when it comes to addressing tobacco product dependency, so I would like to review a couple of key definitions of terms that I'll be using throughout this training. First, let's define tobacco product. According to the Food and Drug Administration, the term tobacco product means any product made or derived from tobacco that is intended for human consumption, including any component, part, or accessory of a tobacco product or a product that contains nicotine that is intended for human consumption or is likely to be consumed, whether smoked, heated, chewed, absorbed, dissolved, inhaled, or ingested by any other means, including, but not limited to, a cigarette, a cigar, pipe tobacco, chewing tobacco, snuff, or snus. By this definition, tobacco product also includes electronic nicotine delivery systems including, but not limited to, e-cigarettes, vape pens, vape boxes, vapes, tank systems, e-hookah, Juul, mechanical mods, e-cigar, and e-pipe. It is important to note here that FDA-approved cessation medications, available over-the-counter or by prescription, including nicotine replacement therapy, are not considered tobacco products. Another key term you'll be hearing in this training is electronic nicotine delivery system, or ENDS. These tobacco products are devices that can be used to deliver aerosolized nicotine and other substances to the person inhaling from the device, including, but not limited to, an e-cigarette, vape, Juul or other pod-based system, e-cigar, e-pipe, vape pen, or e-hookah. Secondhand aerosol, just like secondhand smoke, contains ultra-fine particles that can be inhaled deep into the lungs. There is a misconception that vapes are just flavors and steam. This is not true. Vaping is highly addictive. In fact, one Juul pod contains as much nicotine as 20 cigarettes, or about 1 pack of cigarettes. Vape pods and their aerosol also contain toxins and carcinogens, including formaldehyde, propylene glycol, and acrolein, which can cause irreversible lung damage. And because vaping is new, we're still uncovering its long-term health effects. Electronic nicotine delivery systems, or e-cigarettes, are battery-operated products designed to deliver nicotine, flavor, and other chemicals. They turn chemicals, including highly addictive nicotine, into an aerosol that is inhaled by the user. Most e-cigarettes are manufactured to look like conventional cigarettes, cigars, or pipes. Some resemble everyday items such as pens and USB memory sticks. E-cigarettes are a relatively new tobacco product that have been sold in the U.S. for about a decade. The e-cigarettes currently in the U.S. marketplace have not been systemically reviewed by the Food and Drug Administration to determine their impact on lung health. While much remains to be determined about the lasting health consequences of these products, the American Lung Association is very troubled by the evolving evidence about the impact of e-cigarettes on the lungs. In January 2018, the National Academies of Science, Engineering, and Medicine released a consensus study report that reviewed over 800 different studies. That report made clear, using e-cigarettes causes health risks. It concluded that e-cigarettes both contain and emit a number of potentially toxic substances. The Academy's report also states there is moderate evidence that youth who use e-cigarettes are at increased risk for cough and wheezing, and an increase in asthma exacerbations. As you can see, there are a growing number of different products that are available. Often they are becoming more and more discreet. One Juul pod fits easily into a pocket or the palm of the hand, but it contains as much nicotine as a full pack of 20 cigarettes. Juul and other similar devices are especially popular among youth who were attracted due in large part to their wide range of flavors. While flavors have recently been limited through legislative action, the most popular flavor, menthol, is still widely available. More recently, a heat-not-burn tobacco product has been released for sale in the U.S. in one market. The IQOS device uses a different technology than other electronic nicotine delivery systems. These heat-not-burn products are different from e-cigarettes and other ENDS because they use tobacco, much like a combustible cigarette, and not the flavored e-liquid typically found in ENDS. The IQOS device is currently only being sold in one market, Atlanta, Georgia. The main component of e-cigarettes is the e-liquid. To create an e-liquid, nicotine is extracted from tobacco and mixed with a base, usually propylene glycol, and may also include flavorings, colorings, and other chemicals such as formaldehyde and acrolein, which can cause irreversible lung damage. Again, just one Juul pod contains as much nicotine as a pack of cigarettes. As you can see on this slide, the nicotine strength in these products is extremely high. E-cigarettes contain harmful and potentially harmful ingredients, including formaldehyde and acrolein, which can cause irreversible lung damage. They also contain nicotine. The FDA has found no e-cigarette to be safe nor effective in helping people quit. In fact, more than half of all adult e-cigarette users continue to use regular cigarettes, known as dual use. The American Lung Association is very concerned about the impact of adults and youth inhaling these chemicals and their lung health. According to extensive research conducted by the FDA, these health risks to the lungs and to the brain are what resonates most among youth. We get a lot of questions about whether ENDS can help smokers quit their addiction. The Annals of Internal Medicine produced a study that found smokers who used e-cigarettes to help them quit smoking were less likely to quit than those who did not use e-cigarettes. Only 10% of the smokers who used e-cigarettes had quit smoking after. The most important and powerful tool in quitting tobacco is having the understanding that the highest success rate, after 6 months, comes from those individuals whose tobacco treatment or quit plan includes both counseling plus medication, compared to 26.6% of smokers who did not use e-cigarettes. The Food and Drug Administration has not found any e-cigarette or vape device to be safe and effective in helping smokers quit. Unfortunately, what is more likely to happen is smokers will use both e-cigarettes and cigarettes, referred to as dual use. They don't quit, they switch. It is important as healthcare professionals to dispel the myth that these products are a safe alternative and provide patients with evidence-based tools and FDA-approved safe, proven effective cessation medications. I encourage you to visit lung.org/ecigs to learn more about electronic cigarettes. This slide shows a screenshot of the various resources available. In addition to an abundance of educational information about electronic cigarettes, we also have several one-pagers which include talking points for different audiences. Several of these one-pagers are also available in Spanish. In addition, I would like to take a moment to highlight an American Lung resource that may be of interest to you, the Tobacco Trends Brief. From the ground up, the Tobacco Trends Brief was designed to serve as a resource for many different audiences and goals, from frequently used statements, such as X number of smokers have quit, to very specific queries that can be answered using the extensive tables available in this resource. Charts and maps are also included and can be added to social media, documents, presentations, and other materials as visual support. The American Lung Association firmly believes that everyone can quit. Past quit attempts that result in relapse don't mean that the user wasn't committed to obtaining and maintaining a tobacco-free lifestyle. Many times, these patients just didn't have the right plan in place or the timing wasn't right. People don't have to quit alone. Quitting smoking can feel a little lonely sometimes, especially when a smoker feels like they are leaving their best friend behind. However, no one needs to quit alone. There are tons of groups and resources available to help people quit and stay quit. The American Lung Association has several resources available to support individuals in quitting. In addition, patients can find resources through their health insurance, employer, local health department, hospitals, state tobacco quit line, and on the internet. Having someone on your side during the quit process can make a huge difference and be the exact thing that individuals need to finally quit for good. Every moment free from tobacco use is a success. When we're talking to someone who wants to quit using tobacco products, we often ask, "Have you tried to quit before?" Almost everyone says yes, so we ask, "How long were you able to quit?" If the person says a week and sounds down on themselves, we turn it around by saying, "A week? That's great. We're going to build on that, and we know that you'll be able to quit for good." A person learned how to use tobacco products, and they have to learn how to quit. We sometimes ask people about the first time they had a cigarette, or dipped, or used a Juul. How did it go? Did you master it right away? Most people didn't. Some had a coughing fit, they may have gotten dizzy or experienced nausea. It takes a while for individuals to learn how to smoke or dip or vape. And the same is true for quitting. It's not something they automatically know. They have to learn what works for them. We want people to think about their previous quit attempts and learn from them. What helped? What tripped them up? Use that information to build a quit plan this time, and they'll move toward the right combination of techniques that will allow them to break their addiction for good. It takes most people several tries before they're able to quit for good. How many times do you think most tobacco product users try to quit before they finally become free of their addiction? Once? 3 times? CDC estimates that it takes a person, on average, 9 to 11 quit attempts before they beat their addiction for good. Now, this isn't true for all. Some folks quit after just a few tries, but those who need to make a few more quit attempts are not alone. This is a normal part of breaking a tobacco addiction. We encourage people to think of their previous attempts as practice quits. After all, practice makes perfect. One size doesn't fit all. Wouldn't it be great if there was one perfect way for a patient to quit? One pill, or one book, or one app? The fact is, every tobacco product user is different. Their pattern of addiction is unique, and the combination of techniques that will break that addiction is also unique. Combine medication with a cessation program for the best results. Using one of the 7 FDA-approved medications in tandem with a proven effective tobacco cessation counseling program increases an individual's success of quitting and staying quit by 50%. Only 3 to 5% of cold turkey quitters are successful. So, we strongly encourage use of both counseling and medication for quitting. A slip isn't the same as relapse. Many patients consider a simple slip a full relapse and discontinue their quit plans saying, "I'll try again next week." It is very important that tobacco product users know that a slip is a normal part of the quitting process and isn't an excuse to fully relapse back to their old addiction patterns and routines. Rather, use it as an experience to learn from. Identify what caused the slip and plan ahead for alternatives to keep them on track should the risky situation occur again. As I mentioned a moment ago, one size doesn't fit all when it comes to quitting, because every tobacco product user is different. As you can see on this table, each generation has one thing in common. Their top quit method is cold turkey. But we know from research that only 3 to 5% of individuals who attempt to quit this way are successful. But we do know that the highest chances for a successful quit attempt comes from combining cessation counseling, individually or group, with the use of one of the 7 FDA-approved medications. In the United States, rural communities bear a disproportionate burden of health harms related to commercial tobacco use. Rural populations show earlier initiation rates and higher usage rates of smokeless tobacco use in all 4 United States Census Bureau regions. Commercial tobacco use is disproportionately higher among rural non-Hispanic whites, people with any mental illness, people with substance use disorders, and veterans, compared to their urban counterparts. Rural Hispanics, pregnant women, and sexual and gender minorities also show higher rates than their urban peers on some tobacco use measures. Current smoking prevalence for rural residents was 18.2%, as compared to 12.5% for their urban residents. The table displayed here showcases data taken from the National Survey on Drug Use and Health in 2016. This data refers to persons aged 18 years and older reporting cigarette, smokeless tobacco, and cigar use in the past 30 days. As you can see, rural populations have higher rates of both cigarette and smokeless tobacco use compared to their urban counterparts. The rural population faces some unique challenges in regard to tobacco usage and cultural norms. In certain rural areas, cultural norms favoring tobacco use are prevalent, including states with historical ties to tobacco cultivation. Rural areas face additional challenges in the form of local healthcare provider shortages, lower incomes, and elevated rates of the uninsured. The tobacco industry has historically targeted young rural men by presenting advertisements with rugged images as cowboys, hunters, and race car drivers. In addition, youth in rural areas are less likely to be exposed to anti-tobacco messages in the media. In order to address some of these uniquely rural challenges, some additional considerations are needed to reduce tobacco usage. This includes providing increased cessation options for tobacco users living in rural communities by employing emerging technologies such as telemedicine, cell phones, and web-based applications to address geographic access barriers. Partner with non-physician providers and lay health advisors to mitigate access barriers due to rural workforce shortages. This can include pharmacies, dentists, food banks, churches, and other community or public health organizations. Remove financial barriers that include advocating for improved insurance coverage of cessation, providing free services, and offering financial incentives for quitting tobacco use to address cost barriers faced by some rural residents. A great model to utilize and include in your rural tobacco work is the Ask, Advise, Refer to Quit, Don't Switch model. This model is evidence-based and efficient. This intervention should only take 3 to 5 minutes. It is effective because patients are twice as likely to try quitting with advice from a clinician. No other single intervention will make a bigger difference in saving lives and avoiding the chronic diseases associated with tobacco product use. So, what are the best practice questions to ask patients? It is important that you ask every patient at every visit about their tobacco product use. You want to make sure you ask not only if the patient is a current tobacco user, but also if they might have been a former user or never a tobacco user. This allows us to gauge past behaviors and possibly address a relapse in tobacco use. The next key question to ask is what kind of tobacco an individual used or uses and how often. Simply asking a patient, "Do you smoke?" is not enough. For example, many individuals do not know that e-cigarettes, vapes, mods, Juuls, hookahs, cigars, and chew are all considered tobacco products, and therefore it is important that we directly ask if their no tobacco use includes any of these products. And lastly, it's important to ask if they are interested in quitting tobacco products. In an ideal world, we would encounter patients who don't use tobacco products much more frequently than we encounter those who do. When you do ask the patient if they currently use any tobacco products and they respond no, be sure to acknowledge the patient for making a positive impact on their health by not using tobacco products. The next few slides contain a few sample questions, possible answers, and follow-up questions that are commonly used when practicing the ask, advise, refer to quit, don't switch model. You may notice here that we aren't asking the standard, do you smoke? Asking someone who vapes or uses Juul if they smoke often doesn't yield the correct information because many of these tobacco users don't see themselves as tobacco product users. If the patient responds that they smoke, like is displayed on the slide, make sure you ask specifically which products and also how often they use those products before proceeding on to the advise step. By asking, when is the last time they used a tobacco product, we are able to gauge what stage of quit they are in. For example, if they quit 10 years ago, the individual is less likely to relapse than an individual who quit a few weeks ago. The conversation on this slide displays the common conception by a lot of patients that smoking is not the same as vaping. By responding this way, we are ensuring the individual understands that e-cigarettes are tobacco products. We would want to know if they use e-cigarettes so we can provide the proper resources to help them quit. Because of the recent outbreak of e-cigarette and vaping-associated lung injury, also known as EVALI, it is important to ask patients and document in their health record what type of ENS device they use, along with how often they're using it. Patients who vape are often unable to quantify how much they're using, so asking how often they inhale from their device can be more helpful in assessing the level of addiction to this tobacco product. Remember to be empathic, non-judgmental, and utilize private questioning of patients regarding sensitive information to assure their confidentiality. Vaping has been literally marketed as a healthier alternative to smoking combustible cigarettes. These products have been marketed with the idea that to vape is to not smoke, or at least that's how Juul, with its soon-to-be-retired Make the Switch slogan, would prefer you to think about it. The tobacco industry's aggressive targeting of current tobacco product users in the marketing of both conventional and emerging tobacco products, such as e-cigarettes and Juuls, has led to misperceptions about the safety of these emerging tobacco products, as well as the misperceptions that these products are a safe alternative to combustible cigarettes, or that these products are an aid for smoking cessation. A recent CDC study found that many adults are using e-cigarettes in an attempt to quit smoking. However, most adult e-cigarette users do not stop smoking combustible cigarettes and are instead continuing to use both products, which is known as dual use. Again, by responding this way, we are ensuring the individual understands that e-cigarettes are tobacco products and we can better advise them on quitting options. Over 5,700 kids start vaping every day. Misconceptions, peer pressure, and marketing tactics all contribute to the staggering rise. Talking to your younger patients about tobacco products, especially ENS, is crucial. Often, young patients will deny using tobacco products, and they may not associate vaping with negative health outcomes, like they would smoking. Instead of asking yes or no questions, ask questions that encourage interaction from younger patients. Start a conversation. Ask open-ended questions. Are a lot of people vaping at your school? Be sure you don't react, just listen. Ask, what do you think about vaping? You may hear your patient say, it's harmless, it's just flavored water vapor. This can open the door for an important opportunity to educate your patient. We'll talk more about that opportunity in a moment. Now that we've covered several scenarios surrounding the ask, let's dive into the advise. We want to advise every tobacco product user to quit. Advise those who've tried and failed to try again. We also want to employ the teachable moment, and we do this by linking positive benefits of quitting to their tobacco-related condition. For example, if an individual has COPD or asthma, explaining the positive health benefits quitting smoking can have on their condition may motivate the individual to make a quit attempt. It's also very important to advise patients with a history of dual use that switching one tobacco product for another is not an effective way to safeguard health. Whether consumers are using e-cigarettes, smokeless tobacco, or other tobacco products in addition to combustible cigarettes. Because even minimal use of a tobacco product can be dangerous, quitting tobacco product use completely is an important strategy toward improving health outcomes. And lastly, and most importantly, advise use of both counseling and medication to quit, as this is a CDC best practice. I really want to highlight the teachable moment. This moment will give you the opportunity to link existing health conditions or possibly the reason for the visit to tobacco use. It provides an opportunity to discuss tobacco product use and link health benefits of quitting to their current health condition. As healthcare providers, we may initially want to share the physical benefits of quitting, but we also want to share the social and financial benefits as well as the mental health benefits of quitting. We do this because everyone will have a different motivator to quit tobacco product use. Let's look at connecting the different types of benefits to patients we might commonly see. The table on this slide displays how quitting tobacco can positively affect patients with the following comorbidities. Tobacco product users with cold flu symptoms. Recovering from tobacco product dependence will lessen the symptoms associated with respiratory health complications, strengthen the body's immune system, decrease risk of influenza infections. Tobacco product users with chronic allergies. Recovering from tobacco product dependence will decrease coughing, sneezing, and itching, lessen the symptoms associated with respiratory infections, strengthen the body's immune system, decrease the chances of developing more serious chronic conditions like sinusitis and COPD. Tobacco product users with asthma. Recovering from tobacco product dependence will reduce irritation in your airways and lessen the possibility of triggering an attack, enhance the effectiveness of asthma medications, decrease asthma symptoms. Tobacco product users with COPD. Recovering from tobacco product dependence will decrease serious flare-ups, allow them to be more active, slow the progression of the disease, help make breathing easier. Tobacco product users with cardiovascular disease. Recovering from tobacco product dependence will decrease their risk of heart attack and stroke, decrease their chance of long-term disability, make it easier to manage both blood pressure and cholesterol levels. The table on this slide displays how quitting tobacco can positively affect patients with the following comorbidities. Tobacco users with diabetes. Recovering from tobacco product dependence will increase control over their diabetic symptoms, including improved blood sugar levels. Nicotine in tobacco products causes fluctuations in blood sugar levels as well as causing insulin resistance. Decrease complications, such as blindness and reducing the chances of amputation through improved blood flow. Decrease risk of developing neuropathy. Tobacco users with cancer. Recovering from tobacco product dependence will yield fewer and less serious side effects from cancer treatment, including surgery, chemotherapy, and radiation therapy. Generate faster recovery from treatment. Lower risk of secondary cancers. Provide a better quality of life. Decrease their risk for many other serious illnesses, including secondary infections, heart attacks, and pneumonia. Tobacco users with HIV/AIDS. Recovering from tobacco product dependence will allow therapies to work as intended, provide a better quality of life with fewer HIV-related symptoms, decrease their risk for many serious illnesses, including heart attacks and pneumonia. Tobacco users with mental health disorders. Recovering from tobacco product dependence will improve your mental health, decrease anxiety and depression, improve overall mood. The mental health benefits of quitting smoking are clear for patients with and without a mental health diagnosis. When people stop using tobacco products, studies show that reported anxiety, depression, and stress levels are lower. Quality of life and positive mood improve. Communication barriers can arise in different ways, such as language differences and low literacy. Reducing these barriers is important to improve health outcomes for our patients. When communicating, it is important to use common language, not jargon. Also, keep in mind that not all brochures and written materials may be beneficial for this demographic, although simple graphics and illustrations can be effective. Advising tobacco product users with communication barriers to quit. Recovering from tobacco product dependence will reduce their risk of illness, disease, and premature death. In other words, make them healthier. Saying things like, "Do you sometimes have trouble breathing?" Quitting smoking will make you breathe more easily while climbing up the stairs or going for a walk. Or simply saying, "These products are dangerous and can make you sick. Quitting can make you healthier." There are instant social benefits associated with quitting tobacco product use. Talk to your patient. Ask them if they always have to find a place to smoke with all these laws. Remind them that if they quit, they will not have to look for a place to smoke or be sent outside to smoke. If they're a smokeless tobacco user, they won't have to worry about where to spit. And they won't have to deal with complaints from loved ones about their tobacco product use. More money. These products are expensive, and sometimes focusing on the financial aspect can be a huge motivator for our patients. The table on this slide displays how quitting tobacco can positively affect patients in all stages of life. Teens and young adult tobacco product users. Over 5,700 kids start vaping every day. Misconceptions, peer pressure, and marketing tactics all contribute to the staggering rise. Talking to your younger patients about tobacco products, especially ENDS, is crucial. Recovering from tobacco product dependence will improve athletic performance, improve dental health, prevent wrinkles and skin damage, give them more money for cool stuff, give them back their freedom from their addiction. They will have more time to do what they want to do, not what the addiction tells them to do. Give them control back from big tobacco's manipulation. These companies focus their marketing efforts on replacing former customers with kids by hooking them on their products, often e-cigarettes. Pregnant tobacco product users. Recovering from tobacco product dependence will help the baby get more oxygen, even after just one day. Help the baby grow better. Decrease the chances of a premature birth. Decrease their chance of developing smoking-related diseases. Tobacco product users with children. Protecting children from secondhand smoke and secondhand aerosol will result in fewer coughs and chest colds, lower risk for lung problems, fewer ear infections, fewer asthma attacks, a child who is less likely to use tobacco products. Older adults. Breathe more easily, improve blood circulation, decrease risk of eye diseases that can lead to vision loss and blindness, lower risk of developing osteoporosis. Set a healthy example for your children and grandchildren. With such limited research on the long-term health effects of e-cigarettes and vaping products, tobacco treatment specialists have been relying on what we've seen in the field working with patients addicted to these tobacco products. Talking to patients about ENDS is crucial. As mentioned earlier in the training, people may not associate vaping with negative health outcomes like they would smoking. You may hear your patient say something like, "It's harmless, it's just flavored water vapor." This response is an opportunity to advise these patients about the dangers of tobacco product use, regardless of what they reported as their use history. Vapes and other ENDS are tobacco products, as defined by the FDA. One Juul pod can contain as much nicotine as a pack of cigarettes. Once a person starts vaping, nicotine addiction follows, and quitting can be really hard. We don't even know yet how bad this is going to be for long-term health. There are multiple cases in the news of kids and young adults having seizures from e-cigarette nicotine poisoning, experiencing vaping-related lung injuries, and even death. Let your patients know that people who quit with the help of their healthcare provider have a greater chance of quitting these products for good. This leaves the door open, just in case they ever need your help with quitting. Understanding barriers to quitting is very important to understand what motivates someone to make a quit attempt. It is important to note that these are perceived barriers to recovery by the patient. Nicotine does not in fact help with these, but the user perceives it that way. Patients will often report their concerns about weight gain, stress management, losing their best friend or security blanket. Significant other, friends, family, coworkers use these products. They feel surrounded by tobacco product users. It helps them sleep, or alternatively gives them more energy. Some specifically rural concerns might include they can't stop using tobacco while they do their favorite activities like hunting or fishing because it helps them concentrate better. When they're ready, everyone has their list of the reasons they want to quit, and the reasons can really help them in their quit attempt. Some common reasons people quit are improved health, to have more energy, to save money, to save the aggravation, to regain their sense of taste and smell, and to be a good role model to others. Some specifically rural reasons might be that they won't have to drive 35 minutes to the closest store to buy products. Understanding your patient's specific barriers and challenges, as well as what motivates them, can help you best advise your patient about tobacco product use and help refer them to the best cessation methods when they are ready to quit. You've strongly encouraged your patient to consider quitting by using personalized motivational messages, but they just aren't ready or willing to make a quit attempt. Tell them you understand quitting is difficult. Let them know you are always happy to answer any questions they may have. Finally, assure your patient that you are there to help them quit tobacco products when they are ready. When a patient is ready to quit, the most important and powerful tool is having the understanding that the highest success rate comes from those individuals whose tobacco treatment or quit plan includes both counseling and medication. Assessing for nicotine dependence is an important step in advising your patient to use the best treatment options for their level of addiction. We will now review the Triangle of Addiction, a comprehensive quit plan. Physical. Nicotine replacement therapy medications, prescription or over-the-counter, in the proper doses. Do not stop treatment early. Exercise alternative ways to release dopamine. Use stress management techniques, deep breathing and relaxation exercises daily if possible. Behavioral. Identify your triggers. Use replacements such as cinnamon sticks. Doodle on a notepad. Keep your hands busy. Create change and break routine. Use quit kits, survival kits. Use the 3 A's. Avoid the situation, alter the situation, or alternative, substitute something else. Psychological. Create support systems. Reward yourself for days you avoid use. Mark a calendar for every day you are smoke-free. Continue to attend regular counseling and classes. Understand the myths versus truths of tobacco use. Use positive self-talk. The urge will pass whether I smoke or not, or smoking is not an option for me. Do each every single day. There are 7 FDA-approved medications that can help patients break their nicotine addiction. There are over-the-counter nicotine replacement therapies such as nicotine patches, lozenges, and gum, and prescription nicotine replacement therapies, the nicotine inhaler, and nicotine nasal spray. There are also 2 non-nicotine prescription drugs that can help patients quit: bupropion, Zyban, and varenicline, Chantix. It is very important to encourage medication compliance for patients trying to quit. Most people do not use enough and do not use it long enough to obtain the best benefits from tobacco cessation medications. It is crucial that you provide information on pharmacotherapy options available so that patients can pair pharmacotherapy with counseling for the best results. There are 7 FDA-approved medications to assist with tobacco cessation. 5 of these contain nicotine and 2 do not contain nicotine. A prescription is needed for varenicline, Chantix, bupropion, Zyban, inhaler, and the nasal spray. The patch, gum, and lozenge are available over the counter. Advise your patients on pharmacotherapy by using these key points. Every patient should use pharmacotherapy for at least 12 weeks. Some tobacco product users may benefit from combination therapy, which includes the simultaneous use of different nicotine replacement therapies or medications with different mechanisms of action. Combination therapy with different types of NRT may provide a therapeutic advantage by increasing serum nicotine concentrations. And combination therapy with different drugs may capitalize on synergy obtained from 2 different mechanisms of action. Consider higher doses of NRT for heavier smokers. Treat those at risk for relapse for 6+ months. Persistent strong urges to smoke, higher dependence, comorbid medical or psychiatric illness, past substance abuse, unable to quit on target date. Let's take a few minutes to practice advising the quit, using the techniques and tools in this training. If you would like to practice further after this online module, the patient case studies we'll cover are also available in your resources. If you are watching the webinar in a group setting, I encourage you to pair up and have one person role play as the provider and the other person to play the patient. Watching by yourself? Then practice as if you are the provider. Client scenario: advising the quit via counseling plus medication. Let's meet Chris. Chris is a 54-year-old white female. She is experiencing more frequent asthma attacks. Chris quit smoking 7 years ago. However, she picked up e-cigarette use last year. She says, "It's great. I can puff on it throughout the day, just about anywhere I go. The vape shop owner told me it's harmless water vapor and nicotine. She is excited to finally be able to enjoy nicotine without it impacting her health." Chris doesn't think quitting is necessary, but will listen to what you have to say. Motivators for her are her 4 young grandchildren who comment when she vapes. And her barrier is she doesn't feel vaping is harmful. How would you advise her? Refer to slides 8, 33 under asthma, and 37 for helpful tips. Note: quitting will help her asthma symptoms decrease. Let's meet Tom. He has type 2 diabetes and currently takes oral medication. Tom is concerned about his recent high blood sugars. If he transitions to injectables, he will lose his trucking job and be unemployed. Tom is 62 years old. He is a white male who smokes 3 packs per day, and it keeps him alert while he drives truck 14 hours each day. He has been wanting to quit for a while and has been meaning to try e-cigarettes to help him quit. Tom heard they could help. Tom's motivators are keeping his blood sugars managed, and his barriers are he works long hours and not sure how he will keep himself busy while driving truck. How would you advise him on the benefits of quitting? Refer to slide 8, slide 9 about quit, don't switch, slide 33 under cardiovascular disease, and slide 34 under diabetes for answers. Note: stress balls, toothpicks, cinnamon sticks, and hard candy may help him keep busy. Now meet Eugene. He is visiting today to discuss discomfort from his allergies acting up again. Eugene is a 36-year-old black male, smoked half to a pack a day for 20 years but was able to quit almost 2 years ago by switching to e-cigarettes. Mostly uses his e-cigarette on breaks at work, while driving and on the weekends. Uses a closed pod ends device. Reports going through 2 to 3 pods a week usually. Eugene's motivators are his 2 kids, ages 8 months and 4 years old, and he loves being active with them. Eugene's barrier is he doesn't feel his tobacco product use is negatively affecting him in any way, and it helped him quit smoking. How would you advise Eugene? Refer to slides 8, 9, and 37 for helpful tips. Note: quitting will decrease his allergy symptoms. Meet Peter. He is HIV positive and is currently showing signs of pneumonia. Peter is 27 years old, white, LGBT male. He smokes 1.5 packs per day. Peter has been using a refillable e-cigarette for 5 years when he's at the bars and can't smoke. He usually goes through 1 container of liquid nicotine per week. Peter reports that he smokes daily, even when he is sick. Peter has tried to quit before using a self-help book, but went right back to smoking. Motivators are keeping his CD4 cell levels under control and preventing himself from getting sick. His barrier is he has too much stress in his life, and smoking helps with his anxiety. How would you advise Peter? Refer to slides 34 under HIV/AIDS and 37 for helpful tips. Note: quitting reduces anxiety. Let's meet Tanya. She is a 16-year-old Hispanic female coming in to talk about getting on oral contraceptives. Tanya vapes to and from school in her car and on breaks at work in the evenings, where she works as a server in a restaurant. Tanya reports that she doesn't think it's harmful, that it's just fruity. Both of her parents smoke, and she says she hates smoking because it is so gross and smelly. Tanya has never tried quitting before. She doesn't consider herself addicted and is unsure of how much nicotine is in the e-juice she uses in her vape. Motivators are she cares about her complexion, likes being independent, takes pride in being good at school and having a job. Tanya's barrier is she stated that vaping is no big deal. All my friends vape and they're fine. How would you advise Tanya? Refer to slides 7, 8, and 37 for helpful tips. Let's meet Jen. Jen scheduled a visit to address an ongoing cold that she's had for several weeks. She's 24 years old, 31 weeks pregnant, white female. Previously, Jen smoked 1 pack per day up until her 2nd trimester. Now she uses Juul along with a real cigarette only once in a while when her 2.5-year-old toddler acts up. Jen reports that she feels guilty to be smoking while pregnant, but says, "With the stress of having a toddler, what can I do?" Motivators are that she has a new baby on the way and a 2.5-year-old. Her barrier is that she smokes as a way to deal with stress, has been prioritizing her smoking as me time. And lastly, how would you advise Jen? Refer to slides 33 under cold, 35 under pregnancy, parenting, and 37 for helpful tips. Note: quitting reduces anxiety. Your patient is ready to quit tobacco products, so let's set them up with their quit plan. Remind your patient that the higher rates of success with quit attempts happen for people who use both a quit medication, if appropriate, and counseling. If the patient is interested in using a quit medication, refer them to either their local quit line, which can provide free nicotine replacement therapy in the form of the patch, gum, or lozenge while supplies last, or refer them to their local pharmacy for over-the-counter purchase. If the patient is interested in a prescription quit medication, refer them to their prescriber. Ask the patient if he or she would like to be referred to a program that could assist them with developing a quit plan. Refer the patient or client to local programs, quit lines, and websites. Advise the client of the benefits in checking into their health insurance regarding tobacco cessation coverage. Provide brief counseling and medication, if appropriate. Refer patients to other support resources that can complement your care. Refer patients to other support resources that can complement your care. There are several options available. Encourage patients to look into several modalities. Remind patients that the more tools and support they have, the greater their chance of success. The Pennsylvania Department of Health Division of Tobacco Prevention and Control has partnered with National Jewish Health to provide the PA Free Quit Line and smoking cessation services to all Pennsylvanians 24 hours a day, 7 days a week. The PA Free Quit Line offers up to 5 coaching sessions by phone. Frequency, call dates, and times are coordinated by coach and participant. Unlimited calls to the PA Free Quit Line as needed. Educational materials on quitting tobacco use. Free nicotine replacement therapy for qualified callers, up to 8 weeks of patches. A limited supply of no-cost quit medications such as patches, lozenges, gum, varenicline, and bupropion may be available through the program. You also may be able to obtain some of these quit medications at no cost through Patients' Health Plan. Referrals to regional primary contractors for additional services. Services in both Spanish and English. The Quit Line provides 3 different quit programs designed to meet your style of communication and the support you're seeking as you quit tobacco. All quit programs will help you deal with the emotional, behavioral, and physical aspects that make quitting so hard. Phone and online. Coaching over the phone plus email, text, chat, web-based materials, and quit progress tracking through our website. Phone only. Coaching over the phone plus materials, quit planning, and quit progress tracking. Online only. Materials, quit planning, and quit progress tracking through our website, pa.quitlogics.org. There are various ways to be referred to the Quit Line. Patient using self-referral by calling the Quit Line, or going online to pa.quitlogics.org and completing the enrollment process. Professional using e-referral. Available to healthcare systems or subsystems. E-referral would involve linking up health systems EMR with QuitLogic's website. Professional referring in-office using either Fax to Quit or QuitLogix. We encourage individuals who have access to internet to use QuitLogix as a form of referral. QuitLogix is the online referral site for the PA Free Quit Line. Refer patients who are nicotine replacement therapy eligible. NRT ineligibility consists of the following contraindications: pregnant or breastfeeding women, individuals with high blood pressure and/or heart disease. Tobacco users who are ineligible for NRT due to contraindications must be referred through the Fax to Quit method to ensure a physician signs an approval for the NRT. We will now go through QuitLogix step by step. Healthcare provider and non-healthcare professional referral through PA QuitLogix website. Healthcare providers and non-healthcare professionals that are part of a HIPAA-covered entity can refer patients who have no contraindications for using nicotine replacement therapy and will receive status notifications when the patient has enrolled and if they received NRT. NRT ineligibility consists of the following contraindications: pregnant or breastfeeding women, individuals with high blood pressure and/or heart disease. Tobacco users who are ineligible for NRT due to contraindications must be referred via the Fax to Quit method to ensure a physician signs an approval for the NRT. The healthcare provider section of PA QuitLogix provides guidance on how to talk with patients and includes a demonstration video using the Ask, Advise, Refer model of brief intervention. To refer tobacco users via PA QuitLogix, log on to pa.quitlogics.org. Click on Healthcare Provider. Click on the How to Refer Patients box. On the next page, click on Provider Web Referral. Fill in the patient information section in the upper portion of the page, then fill in clinic information in the lower portion of the page. Clinic is synonymous with provider. Then, click on the Authorization box to indicate that the tobacco user has given permission for the referral to the PA Free Quit Line and the sharing of his or her personal health information for cessation purposes. Finally, click on Submit. We want to advise every tobacco product user to quit. Advise those who've tried and failed to try again. We also want to employ the teachable moment, and we do this by linking positive benefits of quitting to their tobacco-related condition. For example, if an individual has COPD or asthma, explaining the positive health benefits quitting smoking can have on their condition may motivate the individual to make a quit attempt. It's also very important to advise patients with a history of dual use that switching one tobacco product for another is not an effective way to safeguard health, whether consumers are using e-cigarettes, smokeless tobacco, or other tobacco products in addition to combustible cigarettes. Because even minimal use of a tobacco product can be dangerous. Quitting tobacco product use completely is an important strategy toward improving health outcomes. And lastly, and most importantly, advise use of both counseling and medication to quit, as this is a CDC best practice. The American Lung Association in Pennsylvania is offering a pilot telecessation class. This pilot class will provide a cessation resource to patients living in rural areas. Hospitals in these rural areas cited tobacco use as being a major contributing factor to symptoms of chronic diseases seen often in their emergency departments, such as chronic obstructive pulmonary disease, COPD, and chronic heart failure. The American Lung Association and Pennsylvania Department of Health, Office of Rural Health, and Division of Tobacco Prevention and Control teamed up to pilot this program for rural hospitals to offer a resource to patients who wish to quit tobacco. The pilot will be a combination of the Lung Association's Freedom from Smoking program and the Pennsylvania Free Quit Line, providing counseling support via telephone and nicotine replacement therapy. The group telecessation class will provide resources to rural patients to assist in quitting smoking that they may not have otherwise had access to. The use of a telephone conference support line will eliminate any transportation barriers or Wi-Fi access concerns and will allow patients to access the support from the comfort and convenience of their own homes. To refer patients, materials for this pilot program are available for rural hospital staff. In addition to adult cessation, the American Lung Association offers Not on Tobacco. Not seeks to address youth tobacco product cessation by giving teens the resources they need to break nicotine dependency and find healthier outlets. Unlike other cessation programs which simply modify adult curriculum, Not was designed with youth, age 14 to 19, in mind and addresses issues that are specifically important to them. The program takes a holistic approach with each session, using different interactive learning strategies based on social cognitive theory of behavior change that can then be applied and practiced in everyday life, and encourages voluntary change. This interactive self-help workbook is based on the American Lung Association's proven effective Freedom from Smoking Clinic program. It incorporates the latest research in addiction and behavior change. This medically sound program approaches the difficulties of quitting with real-life activities, including identifying and removing roadblocks and triggers, overcoming physical, mental, and social addiction, preparing for quit day, and recovering from slips and relapses. Although the guide uses language geared toward combustible tobacco product users, the activities and information can be helpful for patients that use smokeless tobacco products or ENDS. Contact your local American Lung Association office or email freedomfromsmoking.org for details on ordering the guide. As mentioned before, your state's quit line can also be a resource for self-help materials for your patients. Janice Bankard's introduction to tobacco started early. As a daughter and granddaughter of smokers, the presence of cigarettes wasn't something she gave much thought to. It was just a given. That is probably why, when she was offered her first cigarette at age 10 by a group of older kids she was hanging out with at school, she didn't hesitate. She lit up. It was just the thing to do. Everyone smoked, she recalls. Though she would never call herself a pack-a-day smoker, Janice quickly became dependent on tobacco. Every party involved sitting in a circle of friends and smoking through a few packs of cigarettes, to the point where she would wake up hoarse the next day. But sometimes she could make it a whole week on only one pack. This, compounded by the fact that her cravings didn't come in the morning like many smokers, but later in the evening, led her to believe that her nicotine addiction was minor, not a problem. That is until she found out she was pregnant with her first child. The day I found out that I was pregnant, I literally threw my pack of cigarettes out the window. I quit cold turkey. No program or anything, she said. But that resolve wouldn't last. A few years later, after her second daughter turned 2, she found herself craving a cigarette and promptly went out and bought a pack. She maintained her social smoking habit for many years until a new policy at work made her reconsider quitting. There was talk about all the staff needing to be tobacco-free. When I talked to one of my coworkers about it, she suggested I try vaping. The coworker swore by the product and even sent Janice to her favorite vape shop, complete with a list of all the things she would need to get started. Later that day, Janice walked out of the shop with her first e-cigarette in what would become a line of many. She quickly found her dependence on the product was becoming out of control. Where I used to have to go outside and smoke a cigarette, now I could just puff on the vape all day. I could take a puff between words in a conversation, while watching TV or out with friends. I wasn't even conscious I was doing it some of the time. As she moved on to a more heavy-duty e-cigarette model, her husband and friends expressed concern that she was becoming obsessed. So she tried to cut back by not turning the vape to the highest setting and using pods with less nicotine. Unfortunately, these minor changes didn't seem to make a difference at all. Her nicotine cravings were getting stronger, and she found herself wanting to vape all the time. Even worse, the constant vaping was starting to take a toll on her body. Especially at night, my chest felt so heavy, like a ton of bricks was on top of me. I had only been vaping for about 8 months, but sometimes I felt like I couldn't breathe. I had a constant gurgling cough, and my husband even said that there were times that he would hear me stop breathing in the middle of the night. Thinking it was a sleep disorder, Janice visited her doctor and asked for expert opinions. What she found out surprised her. The doctor confirmed that the pauses in breathing weren't sleep apnea, but may have been a side effect of vaping. This is when Janice decided it was time to quit for good. Though she was skeptical, after doing some research, she decided to try the American Lung Association's Freedom from Smoking class. For Janice, this decision would be the turning point in her addiction. Freedom from Smoking was so helpful because it educated me about what tobacco was doing to my body. The program was really well thought out, and our leader did an amazing job of not only educating, but really making me want to quit. But the best part was the accountability. There were about 15 people in our class, and I didn't want to fail and let them, and myself, down. 8 years later, Janice is still tobacco-free. She admits she still has cravings at times, but says she has found ways to cope, thanks to advice given to her in that Freedom from Smoking class. She even became more involved with the Lung Association, working for the development team for a few years. But one thing is clear, she will never go back to smoking anything. Now that I am a non-smoker, I can tell how gross the habit is. I am disgusted by it. Even though it sometimes makes me unpopular, I will ask people to put cigarettes out if they are around other people, because secondhand smoke is just as dangerous. That is something that Freedom from Smoking really made me think about. And vaping was a joke, it was just a waste of money, and it made me feel worse than cigarettes. Janice is currently living her best life, without a cough and without illness. She enjoys playing with her grandkids and passes her knowledge of living tobacco-free on to them. I am very vocal and even tell my granddaughter, all you need in your lungs is air. The vast majority of smokers relapse after quitting. 90% of self-quitters, 70 to 80% of smokers who receive formal treatment. However, if an individual is still smoke-free at 8 weeks, it is less likely they will relapse into tobacco product use. Following up with your patient is simple and can be very effective in preventing a relapse in tobacco product use. Follow up with the patient at their next visit. Follow-up call is recommended, 1 week after visit and 1 month after quit attempt. Address any challenges in their quit attempt. Adapt quit plan when necessary. Be sure to congratulate them on any successes they've had with quitting. A few simple questions are all that's needed to follow up with your patient on their referral to quit. Are you using any tobacco products every day, some days, or not at all? Have you participated in a counseling program? If so, have you found it very helpful, somewhat helpful, not very helpful, or no help at all? Have you used any medication to help address cravings? If so, have you found it very helpful, somewhat helpful, not very helpful, or no help at all? Are you experiencing any undesirable side effects? Would you like additional help or support to quit or stay quit? The following are keys to relapse prevention. Identify and anticipate high-risk situations. Monitor urges and cravings to smoke. Learn cognitive and behavioral coping responses. Initially avoid high-risk situations. Know how to survive a slip. Most slips and relapses happen during the first week after a person quits, which reinforces just how important following up is. What is the difference of a slip versus a relapse? A slip is a single occurrence of the behavior, just a slip, an error or mistake. A relapse is a return to former behavior or a change in recovery mindset. Encourage patients when you follow up to write down all of their triggers and have a plan for their 2 or 3 main triggers. Either avoid the triggers for a while or find a way to cope with them. If your patient mentions that they had a slip, here are some recommendations to prevent that slip from turning into a full relapse into tobacco product addiction. Advise the patient to get rid of tobacco products immediately. Make a new plan to cope with cravings and triggers. List their reasons to quit. Focus on the benefits of quitting. Ask for extra support from family, friends, or online or mobile support. Use positive self-talk. Practice deep breathing. Drink water and/or increase physical activity when experiencing a craving. Addressing a relapse. You should identify the high-risk situations. Identify intense urges and cravings. Explore coping strategies. Methods of avoiding high-risk situations. Set a new quit date. Develop a plan. Gain support. Choose a different combination of counseling and medication. This might mean changing to a higher level of nicotine replacement therapy, using combinations of NRT, such as using both the patch and the gum, or considering the use of a prescription medication. The long-term strategies to stay smoke-free are to finish treatment and medication, reward yourself for milestones, cope with urges, cope with feelings, build a support team. Remember, NOPE. Not one puff ever for combustible tobacco or ENDS users, or not one pinch ever for smokeless tobacco users. We hope you'll take these tools and best practices and put them to use for your patients today. Thank you for attending this webinar training for the Rural Health Ask, Advise, Refer to Quit, Don't Switch Brief Intervention Training. Patients who see a clinician for a standard clinic visit are more likely to engage in evidence-based tobacco product dependency treatment, resulting in more successful quit attempts and better health outcomes. Thank you. Please contact Caitlin Cluck at caitlin.cluck@lung.org for any questions you may have.